The next session is an interesting topic, high-PEC in GI malignancies. We have two people, Dr. Rahul Chaudhary, who is going to be speaking, Is it the real deal? And Dr. Snita Sinukumar, It isn't delivering. Now, this is another thing which I've been watching for quite some time, with some interest and then with some alarm. And I think the answer is somewhere in between. So both these speakers will take a stand for or against. But I think at the end of the session, some of the senior people should be telling us what is the take-home message. This whole fusion of medical oncology and surgical oncology, should we at all be doing high-PEC in GI malignancies? If we are doing, who's going to be doing it? And what kind of institutes should be doing it? Because I personally feel that we have jumped the gun before the real evidence has come out, and possibly not approach the specialty in the way, and then the specialty gets a bad name. The same thing happened about 20 years ago with laparoscopy. So let's have it. Each of you will speak for 10 minutes, and then take your stand and rebut for 5 minutes, but no repeating your points. Come. Rahul Chaudhary and Snita Sinukumar. Yeah, we can have an audience poll before, for, against, or we can have it at the end. But there has to be a take-home message as to whether we should be doing this at all, and if yes, how. Shouldn't show the result. Okay. So what is B? B is it's delivering. Okay, good. Chalo, good.
Good evening, everybody. At the outset, I would like to thank the organizers and Dr. Bhaduri for giving me this opportunity. Has my time started? Oh my God. So there's nothing to declare, but I do declare I will not be extrapolating data from say ovary. I'll be touching upon gastric, appendiceal, and colorectal cancers. Now, all of us know that liver-only or lung-only meds in colorectal cancer, over the last couple of decades, the lifespan has increased tremendously when we combine chemotherapy and surgery, of course. Peritoneal carcinomatosis, it may be the only site of metastasis in colorectal or GI or gastric cancer in quite a few patients. So, unfortunately, we have not been able to replicate the success we have achieved in lung-only and liver-only disease. I'll skip through the basics. And so, what trials do we have? What level 1 evidence do we have in gastric cancer? Now, when we consider high-PEC, we will not be considering patients with metastatic disease, like liver or lung and elsewhere. These are peritoneum-only meds. High-PEC can be given in two settings. One is when they are peritoneal meds, and the second thing is as an adjuvant setting. Suppose we operate upon T4 or serosal tumor that has breached the serosa, or in those cases, we give it as an adjuvant therapy. So what is the data? So the GastriPEC trial, this is in, the data was presented in ESMO in 2021, and it was a randomized trial comparing cytoreductive surgery with cytoreductive surgery and high-PEC. So there was a statistically significant increase in median overall survival for those undergoing complete cytoreduction, and progression-free survival was also more. So the 5-year OS appeared to be approximately 10% in the high-PEC arm and 0% in the non-high-PEC arm. Now this is in the adjuvant setting. This is from Belarus. This is stage 2 and B2B and 3C gastric cancers who underwent radical surgery plus high-PEC CRS versus surgery alone. So the progression-free survival was higher. Now we see that MPM is metachronous peritoneal metastasis. We see that the development in the high-PEC group, surgery in high-PEC group, is much lesser than the surgery group alone. So this is highly significant. Now this is a paper from Italy. So in the metastatic setting, cytoreductive surgery and HIPEC for gastric cancer with synchronous peritoneal METs. A retrospective study which included patients from 11 high-volume centers. NSCT was given whenever necessary. So the authors, they emphasize that when the PCI was low, 6 or less than 6, when the cytoreduction was complete, CC 0, when these patients have received NACT, and in patients with a negative peritoneal cytology, all these patients did well than the other group. So hazard ratios are on your extreme right. This is a seminal paper from Glehen. This is a paper from France, a multi-institutional study of 159 patients treated with, again in the metastatic setting. They also stated the same thing, completion of cytoreduction and a PCI index of less than 6, but even up to less than 12 did derive a benefit, the blue lines. So HIPEC in colon cancer. So what is the data? So the green ones have been published, the others have not. So when I first started looking up, I was studying colorectal cancer only, and then I actually felt it was an unfair fight, because on the left side you have all these RCTs that are negative, and there's only 2 that are positive in colorectal cancer, and Combotech, it had to be terminated prematurely because of less patient accrual. However, this was a positive trial, and there was a 4-month benefit in DFS. So we'll begin with the trial from Netherlands. Long-term follow-up of this trial has been presented, and it consisted of 105 colorectal patients with proven peritoneal METs. Patients were randomized to have CRS plus HIPEC with mitomycin, followed by systemic therapy versus standard therapy, that is systemic chemotherapy alone. So both the OS and the median disease-free survival was significantly increased, again in patients who were able to have a complete cytoreduction. Now, we are here, we are debating because in 2018, a landmark paper was presented, the Prodigy 7. It was a randomized trial which consisted of 265 patients with PCI less than or equal to 25. Patients received NACT. They were randomized to undergo surgery with CRS plus HIPEC versus surgery with CRS alone. And this trial used a bidirectional systemic chemotherapy with 5-FU and folinic acid delivered 20 minutes IV before HIPEC, which used oxaliplatin, for 30 minutes. And they said there was no survival benefit. And however, if you look closely, 10% patients were rectal cancers. Rectal cancer is a different disease. Treating patients with NSCT with oxaliplatin may have conferred some resistance. The HIPEC used a very short duration for oxaliplatin. Crossover was allowed whenever patients developed peritoneal METs. OS may be not a very good way of measuring an entity in a trial when it is a local treatment, because HIPEC is actually a local treatment. But even in this trial, patients with PCI 11 to 15 had a prolonged DFS with addition to HIPEC. There's another negative trial, ColoPEC, again used the same protocol, and Profilochip. This again was presented recently, and it was again a negative trial, but it included both M0 and M1 patients together. So it is difficult to consider, to actually verify these results. So appendiceal carcinoma, we know that in low-grade neoplasms, it is a treatment of choice. RCT by Viraval, it had included cases of C appendix, and there's a recent trial that was published. I think it was from Spain, US. They compared mitomycin C with, this was from US, compared mitomycin C with oxaliplatin, and they said that long-term survival is possible if cytoreduction is achieved. Now, the problem CRS is, is that the number of drugs that have been used, they are region-specific, country-specific, and institute-specific. So all these drugs have been used, either singly or in combination, mitomycin, oxaliplatin. And most of the negative trials, they have used oxaliplatin for 30 minutes. But there is evidence to show that short-term HIPEC is unable to penetrate deep enough into cell layers. If we see two colon cancer cell lines, these are SWS cotton white 620 and WIDR cell lines. These are colon cancer cell lines. When they were subjected to oxaliplatin under 42 degrees, we see the bar diagram on the both above and below, the right one. So when it was for only 0.5 hours, that is 30 minutes, the cells grew. I mean, the oxaliplatin did not have any effect. Whereas when it was for 0.5 hours, I mean half an hour, it did not have any effect. But when it was for 2 hours, it had it inhibited cell growth subsequently. So I feel that when we have used oxaliplatin for a short duration, and we are completely relying on that data, it is probably unfair. There are other trials in the pipeline. Again, Promenade, unfortunately, is using the same regimen. And we've probably set the bar too high, and we need to go back and look into it. So points to ponder, HIPEC is a local treatment aimed at local control, is an adjunct to CRS. It is akin to short course NACT for rectal cancer, which results in low recurrence rates, but does not affect DOS. So conclusion, HIPEC works and in conjunction with complete CRS. PCI less than or equal to 6 in gastric cancer, less than 15 in colon cancer is probably, these patients may be probable candidates. The drug to be used and the duration needs to be agreed upon. The morbidity is acceptable. This is a paper again saying this. This picture, in Germany, they used to have large baths wherein the man of the house used to have the bath first and subsequently the women and the children and then last the babies in the same bathtub. And eventually when the bathtub, the water would get really dirty. It was easy to lose a small baby inside. So HIPEC is a baby. Don't throw it out with the bathwater. Thank you.
Thank you. Thank you, Rahul.
Thank you, Dr. Rahul. So you see, I'm in a bit of a pickle now because I am a HIPEC enthusiast and slides are not showing. I'm a HIPEC enthusiast, but I am not biased. And I'd really not like to say that HIPEC has no role in GI malignancies. What I would like to put here is that, are we really ready to accept HIPEC as a treatment modality for peritoneal carcinomatosis from colorectal and gastric peritoneal cancer? Now, I'm here to present the other side of the coin. There is a lot of retrospective data supporting the role of HIPEC in colorectal peritoneal metastasis. What I'm going to do today is present a different perspective on cytoreductive surgery and HIPEC. Now, these are a few papers. Already Dr. Rahul has explained and expanded on the importance of the Wick-Verwald trial in 2008, where there was a clear benefit of perioperative chemotherapy, cytoreductive surgery, and HIPEC versus systemic chemotherapy. If you look at all these trials, what you can see is, multimodality treatment versus unimodality treatment. I don't think this is fair. Now, just to bring your attention to the last study, again, a retrospective study. What is happening now is perioperative chemotherapy, cytoreductive surgery, and HIPEC now being compared with systemic chemotherapy and cytoreductive surgery. You can see the survival difference, not much. This is precisely what was done in the PRODIT-7 trial. Now, most HiPEC enthusiasts and proponents would believe that probably they got the wrong at the end of the stick with this trial. We were looking forward to HiPEC emerging as a hero in this trial. However, as you can see, it was not HiPEC, but cytoreductive surgery that emerged as a winner. What I would like to emphasize over here is that cytoreductive surgery, an aggressive cytoreductive surgery, is what is the logical premise to the treatment of peritoneal carcinomatosis from colorectal cancer. Now, what is the additional role of perioperative chemotherapy? What is the additional role of HiPEC in cytoreductive surgery? Is a question that is not yet answered. And perhaps that is the answer we are looking for. The additional benefit of chemotherapy, systemic chemotherapy, or the additional benefit of HiPEC to this aggressive surgery to add to overall survival benefit. And that is precisely what forthcoming studies by HiPEC enthusiasts are going to answer with the Cairo 6 trial and the Interact trial. This precise answer that whether perioperative chemotherapy and cytoreductive surgery is more effective or cytoreductive surgery with HiPEC is more effective. Yes, these are negative trials, already absolutely no role to date to recommend HiPEC in the adjuvant setting and prophylactic and the prophylactic setting. So to summarize, HiPEC in colorectal peritoneal metastasis, there is a very, very strong rationale. It is logical because, yes, peritoneal carcinomatosis is a loco-regional disease, so we need to establish loco-regional control. The initial euphoria surrounding HiPEC has definitely fizzled out, but the enthusiasm has not died. It still continues. We need to have more evidence. We need to have more clarity on the pharmacokinetics and patient selections to recommend HiPEC in colorectal carcinomatosis. And today, as part of routine surgical clinical practice, we certainly cannot recommend HiPEC in colorectal peritoneal carcinomatosis, only to be done by specialized oncology centers and only to be done by personnel with expertise in HiPEC care. Let's move on to gastric cancers and HiPEC. Now, again, there are indications and rationale. The most common indications are prevention of peritoneal recurrences from high-risk T3, T4 disease and cytology positive, and is in the scenario of established peritoneal metastasis. It isn't surprising that the majority of the data that we have for HiPEC is in the prophylactic setting, where locally advanced gastric cancer has got a higher propensity or probability of developing peritoneal carcinomatosis. But if you see the evidence, some of them are randomized evidence, most of them are randomized evidence. They are level 1 evidence, meta-analysis. But what you can see is that surgery is the treatment that has been compared with HiPEC. Okay? Want to draw your attention to this. The treatment arm is surgery. This is locally advanced gastric cancers. Surgery alone versus surgery and HiPEC. The median OS benefit is modest, 6 months to 18 months, and the morbidity is extremely high, 5% to 40%. The absolute premise for introducing any clinical trial, any new treatment modality is to first establish the safety and to decrease the morbidity. Once that is established, only then can it be introduced as a standard of care. Now, where is the perioperative chemotherapy here? We all know that perioperative chemotherapy has been doing so well for locally advanced gastric cancers. That has not been taken into consideration in all these trials. So in the absence of perioperative chemotherapy, we really cannot consider HiPEC and cytoreductive surgery as the standard of care for locally advanced gastric cancer for prevention of peritoneal metastasis. This is exactly what the GastriChip study is going to answer, the role of perioperative chemotherapy in locally advanced gastric cancer after a surgery, and also the addition of hypothermic chemotherapy, whether it is going to add any survival benefit or not. The results are going to be released in 2023, and we look forward to answers from this trial. The second indication for gastric peritoneal carcinomatosis of HiPEC is in gastric peritoneal established carcinomatosis. Again here, in the metastatic disease, with systemic chemotherapy, the median overall survival is absolutely dismal. It's 5.5 to 18 months. What more can be done? If you look at studies with gastric peritoneal carcinomatosis and HIPEC, the median overall survival, again, the difference in the benefit is not very great. It's quite modest, but the morbidity is extremely high, 14.7%, 88%. So this kind of morbidity cannot justify the aggressive surgical treatment in the absence of very modest survival benefits. The other thing that I would like to bring to your notice is that in all these studies, the median PCI has been extremely high. The survival benefit has been modest, and the morbidity has been extremely, extremely high. Even with the latest studies, as you can see, in order to balance out the survival benefit, there has been a patient selection. So as you select patients with lower volume disease, lower PCIs, the median overall survival does increase, but the morbidity still continues to be high. So till we have an acceptable morbidity for patients with gastric peritoneal carcinomatosis, and we clearly define what is the role of perioperative chemotherapy, what are the ideal patient population that can benefit from a cytoreductive surgery and HIPEC. The role for HIPEC in gastric cancers continues to remain strictly experimental. There are several unresolved issues. There is a strong rationale, but it is still, there are a lot of issues that need to be clarified. Careful patient selection is extremely important. Defining PCI is extremely important. And the importance and the role of neo-targeted agents also needs to be considered before considering HIPEC in gastric peritoneal carcinomatosis. So I end my talk here.